Hi, everybody. This is Rajam Roos. I'm the CEO and founder of the San Diego Pain Summit, and I am here with this discussion with Dr. Mark Kargela, and he has agreed to spend a little time talking with us here today. And he's a clinical assistant professor at Midwestern University in Glendale, Arizona. He received his Doctor of Physical Therapy of degree in 2003 and completed a fellowship in orthopedic manual physical therapy in 2012 from Evidence in Motion. He serves as a manuscript reviewer for the Journal of Manual and Manipulative Therapy and the Journal of Orthopedic and Sports Physical Therapy. He has taught continuing education coursework to physical therapists around the country within Evidence in Motion's fellowship program and continuing education courses up until 2016. He is the founder of Modern Pain Care, a continuing education company where he lectures and teaches continuing education focused on updating physical therapy practice with modern science. And in his current role, Dr. Kargela supervises and practices in the Physical Therapy Institute at Midwestern University, and he also lectures nationally on chronic pain and incorporating modern science and current best evidence into physical therapy care and manual therapy treatments. And so, there's a lot of mouthful of words there. But anyway, so, what's really interesting is I read this, a woman posted a blog on Medium. I believe her name is Rachel German, and I just read it today on Twitter. Did you see that? It's called Running as Fast as I Can.
I've seen, it's on my to-read list, but I understand some of the topics that are discussed there are some pretty sensitive topics within our profession as far as burnout and clinician productivity and different things, and things that I think are good topics we should be discussing as a profession, because it's kind of eating up our new grads and spitting them out and kind of disenfranchising a good portion of our workforce. So I hope it stimulates a good discussion that can hopefully lead to some positive change.
Yeah, reading that, of course, I'm not a physical therapist, so I didn't really I had no clue about all of that going on in the background. But, when it comes to manual therapy, what are your thoughts about how the profession is progressing?
Manual therapy, I think, it seems like in a state of flux right now. I think there's been an initial and criticism of manual therapy, and I think a rightful criticism. Adam Meekins is a colleague and probably a digital friend, and he's, come out pretty strongly against manual therapy as far as that it's maybe not the best way we could be spending our time with patients, even going as far as to say manual therapy sucks. And I think those are good criticisms we should be taking into account with manual therapy, because science is telling us we should. It's not, I think that's a tough thing. It's and this is somebody who, when I was going through my manual therapy fellowship, I was going into that thinking that manual therapy was going to be the reason I could solve these complex cases. It was just because I hadn't been fellowship level trained. I hadn't gotten to that Jedi level of manual therapy that was going to take me over the hump with the patients that were struggling in my clinic. And it was a pretty hard realization that, it isn't about technique and further manual therapy. It's about understanding the human being that's behind those symptoms and restoring the humanity of that clinical encounter. And a lot of that is due to pain science and kind of what the science of pain is telling us when we think biopsychosocial approach, and not just getting so hung up on the bio and pontificating over facet glides and all these minute biomechanical things that we like to nitpick over as manual therapists, and understand that, man, that input from whatever joint you're touching or evaluating has to travel through a nervous system that's where the human's experiences and life and conceptions and perceptions of everything you are doing lie. So we probably need to understand the human being that's behind it. So I think manual therapy is still struggling to maybe move forward from still getting very technique focused and everybody gathering at the same manual therapy conference every year and patting each other on the back that, hey, we got it all figured out, or hey, we're still going to do our manual therapy, but let's have a little pain science in the background so we can say we're staying updated with science. I still think there's more we can do in the manual therapy profession to recognize the limits of manual therapy. And I think a lot of manual therapists I know are, but being able to say that manual therapy isn't the best solution for every patient that walks through our door. As far as for a physical therapist, I know a lot of massage therapists, that's their mode of interaction with the patient. There's nothing wrong with that. And they do a wonderful job with that. But like for my colleagues in physical therapy, I think we have, that can be part of our approach. But I think when we're trying to get humans back to valued goals and valued activities, I think laying on a plinth and having somebody do something to you is not maybe leveraging the best of our skills that we have as a doctoring profession in physical therapy.
Yeah, it's interesting because that seems like a huge, massive shift that needs to happen in the training programs and just in the profession. I like that reminds me of Jason, Dr. Jason Silvernail's first talk at the 2015 summit, where he talks about viewing the patient having a navigation system to help you work with the patient, as opposed to like the tools in the toolbox.
Yeah. Yeah. No, I love Jason's process versus product talk and then kind of crossing the chasm. But yeah, I think we do need more of a process and a clinical thinking process to really help us understand the complexity of an experience. And it isn't about what tool you can throw next at a patient. I'm not saying, and I don't think Jason would say that they're not important. It just, they don't mean much if you don't have a strategy of when to pull out the hammer, when to pull out the wrench, and maybe when to put all the heavy tools away and just sit down and listen and try to, connect with a fellow human being. I think Jason's probably been one of the bigger influences on me, just as I've kind of made this transition from being a very strict, and I don't even call myself a manual therapist anymore. I call myself a physical therapist who utilizes manual therapy at times with patients. But yeah, he's a great mind and who's had some great impact and influence on a lot of clinicians besides just me. But I think that whole thought of having a system, having a process, and understanding how it all fits to the human in front of us instead of us fitting the human to us, and kind of shoehorning everybody into a manual therapy program, maybe not be the best interest of all our patients. Although definitely there's some that can benefit, and we've seen that with research and different things. It's just recognizing there's more to the human pain experience than what lies under your fingers with a manual therapy technique.
So what do you think are some of the barriers to, the physical therapy profession moving forward?
I think we have some authorities out there who are seen as authorities in the manual therapy world who I think struggle just like any human does. It's a human thing. I think when you get this cognitive dissonance of, I've spent a whole career, I publish in this journal, they're up in manual therapy, associations and different things where manual therapy has just become their defining thing as a physical therapist. And I think, I've really encouraged my students and folks that I work with on courses, just, you should never be defined by a technique, because especially with what we know about science, science doesn't give a rip about your technique as far as it's going to, prove it right or wrong or in between. And manual therapy has some benefits, but it's no panacea, and there's no real evidence to show that it's amazingly special compared to a lot of other passive interventions. But I think that's one of the bigger barriers. I just think we have a lot of folks who that cognitive dissonance effect in the authorities of our profession. And these were the same reactions I had when I was first encountering pain science. I had a little bit of a gruff reaction to, I was on Soma Simple was the website.
Oh my gosh.
That was a real mind bender for me. And it was like, there were people on there I did not like. And,
yeah, I thought they were all jerks and they hated massage therapists, but I kept going back.
Yeah.
And reading
it's like,
and then I'd get all worked up and then I'd leave it and then go back. And then, I finally realized, okay, if I don't take that personally, then it's not,
yeah, it's hard not to. I mean, and the more I read, it's just you're being a human being who's, you get, a lot of us have spent a good deal of money and time and effort to develop our, niche in our professions. And, it's hard when you see that stuff getting challenged. I had spent my career getting the latest certifications and letters after my name to be a manual therapist, thinking that was the answer. And then I had this website saying, no, it's not really the way that's going to happen. And, this whole operator versus interactor thing. And it just blew my mind, and it made me angry at first, because I was like, this can't be, I can't have wasted my time. I don't think I've wasted my time looking back. I just think I really missed out an opportunity to really diversify myself and not tunnel vision myself and define myself by being a manual therapist as much. But again, I've learned, it's been a valuable journey. You got to ideally learn from those type of things. But yeah, cognitive dissonance is a tough one.
I'm sorry. I was just going to say, when you're talking about that, what do you think how do you think that you were able to finally overcome that? Is there anything specific that you can think of that helped you, get over that hump
I,
of cognitive dissonance?
yeah. I think I had to let that message sink in. I had to just, and I had some people like Jason Silvernail. I remember Rod Henderson was on there, John Ware, and some other folks that were kind of prodding me a little bit in a good way. And they weren't being mean or nasty. But I think I had to sit on that message, and I had to kind of let myself kind of dig into the research a little bit, and then kind of really evaluate it in my practice and just think, is what I think really the way it is? And then obviously, our thinking can get biased hugely, and then you start getting into a lot of rabbit holes when we get into the whole cognitive biases discussion. But yeah, I think it just took being real with myself and being real with what I was seeing in the clinic, and really reflecting on my experience, because I've been privileged to really be mentored by a very variety of people who all would probably consider themselves manual therapists, but probably all have different ways they interact and use. Yet they all have probably, and some of them approach patients very differently. Yet they all have people who loved it and thought it was the best thing. So if it was all about specific techniques and all these things, it never lined up with me, and it never lined up with me when I'd see patients emotional and crying and all these human things that would come into your treatment room. Yet we would just sit there thinking that, oh, well, you just need to develop better hands. And that just never made sense. How does hands going to help me with that? The person's crying, they're angry, they've lost their job, they're losing their identity, they're doing all these things. Yet I was pursuing this hands pursuit. And in the end, that just never made sense to me. I never was one in classes that could say I was feeling the SI joint move a millimeter with my fingertips. It just never was something I'd go to courses and everybody's, oh, can you feel that? Sure. And you're just kind of, I think, saying that just because you get into that tribe, groupthink mentality there. But
Yeah, and you start to feel like you can, like, because I've taken cranial sacral therapy, and you're supposed to be feeling the pulse of the cerebral spinal fluid.
Yeah. You're the easiest person to fool. I can't remember. I think it's Feynman that says that, but beware, because you're the easiest person to fool. And it's true. I think we can convince ourselves to some things that really don't have a lot of founding in science. And I think that's just something you have to, I think, have this whole metacognitive process to where you're evaluating your thinking and you're recognizing that where are my biases, and you kind of run a audit, I guess, of yourself regularly to say, am I getting down some rabbit holes too far? Am I really? And that's where you just surround yourself with people that just don't agree with you and pat yourself on the back. That's, again, why I get frustrated with manual therapy colleagues who just go to the same freaking conference over and over again and get the same confirmation bias over and over again. I'm not saying that those conferences can't bring some value, but man, diversify your thinking and surround yourself by people who don't think the same way. So you might learn something, you might grow. I know I have hugely. I think surround myself by people who don't do any manual therapy, who are in the psychology realm, and Bronnie Thompson's who do, she's obviously an occupational therapist and PhD and doing some amazing stuff. Those have been my greatest learning experiences since I've kind of gotten into the whole pain science thing.
And it's interesting too, something that you touched on, which another thing I happened to see, actually I saw it yesterday on Twitter, and it was a research paper showing that there is some benefit to a treatment session where the patient creates their goals, and the patient leads the progress to get there.
Mm-hmm.
And I was thinking about, when you're talking about manual therapy progressing and that shift that needs to happen, it seems like that's where it needs to kind of go more towards, instead of us setting the goals. Really, it's also the insurance companies are setting the goals, and then, or it seems like it, because you bill for the hours or the codes for billing. But it seems like that would be part of that shift, is letting the patient set their goals.
Yeah, I definitely would agree there. I think, we have so much data on therapeutic alliance and patient expectations. And when you set goals that meet their expectations, and you're really tapping into what are the things that drive the patient as a human and as a person, what are the things that really they're missing in their life that pain is limiting them from doing. And that's what you focus your session around, not I'm going to restore the glide to a normal mobility glide at the SI joint on the right side. Patients don't give a rip about that in the grand scheme. They want to be picking up benches. They want to be able to walk up a flight of stairs. But I think we get so caught in our normative clinical world that we forget sometimes that there's a human on the other side that, and again, you go to 10 different physical therapists, they'll have 10 different biased ways of and narratives that they've learned through their approaches, craniosacral, manual, whatever it may be, that are going to give them 10 different stories. But again, I think we should stop telling stories that relate to us and start, creating stories that relate to the patient and what makes them tick and what makes them really have a desire to get to back, what are the things that make them happy and bring them joy in life. And I just think sometimes our professional egos, I think, get in the way of that.
Have you seen that video that Greg Lehman likes to show at his talks?
I'm not sure. I've taken Greg's class, so if it's been in his class.
So he has this video, and he likes to show, when he's spoken twice at the summit, he showed it both times. But it's it's at a conference in San Diego. It's like a shoulder conference.
Oh, yes.
And he's like showing how the guy's shoulder's all messed up. And then finally he starts to do some manual therapy, and the guy's like, is the other shoulder.
Yeah, it was like this renowned orthopedist who was all about scapular dysfunction, and he's pathologizing this. It was like a teenager's, I think it was his right scapula, and they're like, oh, look at all these bad things happening at this scapula.
And how it's not moving right and all this and that.
It's got all this dyskinesia and all these different things going on. And then he turns around the kid to face the audience and he's like, well, where's your pain again? And he points to the other shoulder. So it had nothing to do with the shoulder that was supposedly. That's a perfect example of what you said, like how we can talk ourselves into a lot of stuff.
I think we've all been there. I mean, I think we've all been working with clients or patients because I used to stand, my clients against the wall, and I used to do the muscle test, firing patterns and all that. So I think we've all been there. None of us are innocent.
I think that's the thing too, is I think, anybody who's, discussing lecturing, if they aren't coming clean and saying that they've made the same mistakes that they're trying to prevent you from making, that's one of the big things when we teach courses. They recognize that anything we criticize, that these are things we've done, and we just try to help you not do yourselves, and maybe, save some of the, the frustration that, we go through as we're learning and improving. But that's, I think we could all probably have a session where we went around, and we've done it. I think, and I've definitely done it at the San Diego Pain Summit, where we'll sit around over beverages and talk about all the things we used to do with patients and things that our careers as we've kind of grown and improved ourselves. But I think that's part of any profession. You probably cringe at a good chunk of what you did earlier on, and thinking you all had it figured out at that time. I know I did. Coming out of school, I thought I was going to be a rock star, and just till patients start coming in and not making sense the way the textbook claimed it would be, and then it becomes a challenge.
I'm curious. I actually had a discussion with Sandy that's going to be part of this online pain summit. And we were talking, she was talking a lot about some of the reasons why it's not easy for clinicians to, make that shift in their practice. And a lot of it having to do with the owner of the clinic and how insurance is billed and all that. What are some ways that you think that someone watching this who wants to work in that way with their patient, what are some ways they can start doing that if they're running an insurance-based practice?
Yeah, no, that's a good question. Because we teach, at Midwestern University where I'm at, I lecture frequently, and I run into, students say, well, what if I have 2 patients in at the same time, 3 patients in at the same time? I think, it makes it challenging for sure, because you're trying to have a human interaction amongst 3 other humans. But, I think, you train your support staff, you have PTAs or PT techs that can, that can understand that, hey, you need to understand their thoughts and understand kind of where they're at as a person and different things, and maybe try to tailor things. So you try to train your support staff. You do your best in those scenarios. I mean, there are times where I think a person just needs to be sat down and you need to listen and talk. And I think, unfortunately, we do have a lot of clinicians who get stuck where they just don't have the time. I think you just have to be creative and find the time, like during exercise, during manual therapy, you start having these discussions, so it's not like you have to cordon off. And I don't think, we never would teach it that way anyway, where all of a sudden it's like, here's my pain science time and here's my manual therapy time. It's all one. I'm talking, as I'm laying my hands on, I'm giving them good narratives of what's happening. I'm not telling them they're broken, damaged goods. I'm trying to give them a thought that we're just kind of modulating the experience a little bit to help them move better at home. And then, get to know, hey, so how, I see, I can feel kind of what's going on, and you've told me what's going on in your body, what's been going on in your head, around what's going on, and you have some discussions and you see if you can't, find a way to have that human interaction, even in the midst of a maybe high productivity setting. But you got to be creative sometimes. You got to be creative. And in the end, if it gets to the point, I've told students, I mean, in the end, you got to make your own judgment. If it's just somewhere where you can't, where you don't feel like you're able to provide the care that science is telling us we should be delivering, then, maybe it isn't the environment for you. I've had to make that decisions earlier in my career where I wasn't interested in productivity over good patient care. And I know plenty of insurance-based practices who don't stack patients like 3 to 4 over a time. I know some patients or practices who are one-on-one, and granted, they're not, probably not the wealthiest practice out there, but they're keeping their doors open and different things. But I also know some practices who do like 2 at a time. My friend, Jared Hall, a good friend, and I think he'll be on this with you. He has some times where he's got multiple patients at once, and does a wonderful job integrating this stuff. So you just
He's got a lot of energy too.
Yeah, he's got a lot of energy.
Week, yeah.
he's a young clinician. I just think you just got to be careful with the burnout factor. I know as I've gotten into my 15th, soon to be actually 16th year this year, that it can wear on you a little bit, because that clinical grind of cranking documentation late after work, early before work, and scrambling during the day to keep up. It's a grind, and I just think you have to. I admire Sandy and Sarah over at Entropy up there in Chicago. They've created their own thing, and they've got an amazing place that's probably embodies what you would want to have as a clinic, not only from a patient education standpoint, but from a clinician education standpoint. So there's some people out there to emulate if folks are looking to kind of figure out how they can navigate that. Sandy and Sarah would definitely be 2 folks that I would pick their brains if I was looking to do something, and I actually have talked to them in the past about different ideas I've had as far as clinical care and practice. So yeah, find the people who are doing it and talk to them and see how they make it work.
That's a good point. And in the emails when I was asking if you wanted to participate, you wrote this sentence that I found really interesting about things that you might want to talk about, and you wrote contextual effects and how they can drive outcomes. And I'm curious what you mean by that.
Yeah, I think we don't recognize. I mean, I think there's a lot of research that talks about context and placebos, and if you read anything from Fabrizio Benindetti, he's kind of like and Luis Cloca, I think, is another big researcher in that realm. But we should all read that stuff, because it just goes to show that we've biased ourselves to think that when there's a positive response to our treatment, that it's only the mechanisms of our treatment that it can keep you in a rabbit hole of getting so excited about your treatment, but we lose there's a lot surrounding our treatments, and it could be the marketing that went into that treatment and the popularity of the treatment. Well, Michael Phelps just is getting cupped. I want to get cupped now too. And I mean, all these things that can generate positive, and that's not necessarily these are bad things, but I think ideally it tempers our excitement about interventions, because there's a huge amount of things that can make an intervention have a positive. You're biased as a clinician you're going to interact better with the patient with something. It's like I always say to students, like, if you're an actor who knows the lines and you can perform them well, and you've developed all the body language and things around your lines because you've done it over and over again, you're going to develop a much better interaction with your audience than if you're like learning these lines for the new time. That's why I'm always also struggle with like research studies where it's like the clinicians will perform their favorite intervention that they do so well and communicate amazingly to patients, and then they'll compare it to this other intervention that they don't really think is as efficacious, and then they wonder why. The one that I'm all about is more exciting, or more efficacious and gets better outcomes. Well, Chad Cook
talks about you're more confident, right? And if you're confident about what you're doing, you're going to make the patient feel at ease.
Yeah, if anybody's followed me on social media, I rail with clinical equipoise and personal equipoise. That's Chad Cook's really been the person in PT that's kind of brought that to the forefront. But it's this state, ideally in any research study, that there is a lack of belief that there is one intervention arm that's going to be better than the other from the folks that are performing the studies. That doesn't exist, of course, in any study, but the problem is we have people who doing manipulation studies, and we got people who do dry needling studies, and shocking that they get better outcomes with that. There's ways to combat that. Chad Cook talks about, let's get experts on both sides. If you're going to want to compare dry needling to mobilization, then get experts on both and compare them instead of getting experts on one doing both. And of course, there's going to be a biased application in those. That's just because we're humans, But Yeah, I just think that whole contextual effects thing, I think is just, there's so much that dictates the outcome. And it, to me, it goes back to what Lewis Gifford said, is if you could all understand you're doing the same thing, you're playing with processing, but instead, you miss an opportunity to help a great deal more and sell a lot less. But it's just, to me, I think a lot of it is we have a narrative and an approach that brings us to where we can perform or can portray it well to our audience with confidence, that generates the expectations, that generates the context that's going to prime a patient for an outcome. And that's not bad. We should recognize it, but that just, we need to go past it, recognize that, hey, this is a big part of it. But patients don't live in your therapeutic contents. They live in the context of their lives. And that's where I think we have to just recognize that those are the contexts that we need to move towards, as far as not saying we're going to go always treat in that context, but help a patient navigate that context, because that's the one that is meaningful to them. And stop getting so excited about the latest technical context you can create in your clinic that generates an outcome because you're newly excited about it and portray it well to a patient well. And again, I'm not trying to discourage people from searching out technical knowledge. I just recognize its limitations and recognize there's so much more we can do as a patient with patients and helping them in their lives than just getting stuck on technical components of their care.
Yeah, that's good. I like that.
Yeah, I get. It's tough, in a university setting, where I got to be careful, too much about, because students, it's pretty destabilizing when they experience when you got somebody saying maybe manual therapy techniques aren't as amazing as we thought.
Mm-hmm.
I know for me, I thought that was going to be the keystone of my, ability to help somebody. It's still a good part. I'm not saying it doesn't help with the right patient at the right time, but it's definitely not anything I would put as a foundational piece of my practice. It's, being a good clinician, part of it can incorporate manual therapy, but it doesn't necessarily need to be a must for every patient. I let the patient have some help guide me and guide each other to what might be the most helpful thing for them that day.
So if you're thinking about, as making that shift where you're working with the patient and using your navigation system and you're not so focused on techniques and tools, if you talk about barriers to this shift, what would be, like if you said cultural barriers, does that mean the culture of the workplace or culture of what people expect when they come in?
I think both, really. I mean, we have so many different cultures. It's our professional cultures too. I think we limit ourselves by creating a culture that healing is going to be through somebody else's hands. I think you got to recognize that creates expectation and treatment effects just through this belief that we create in our public that somebody's hands need to realign or unstick or do whatever kind of, manual kind of traditional way we think about it. But definitely, the patient's culture, whether it's at their workplace or in their family or whatever that could be influencing it. But I think we just have to recognize that those cultural influences are there and try to understand to the best of our ability. That's why, again, getting to know the human being in front of you of kind of how their workplace culture functions, maybe how their ethnic culture reacts to pain, because you get people of different cultures, they have different views and different beliefs around pain that you can't assume align with yours. And just asking a simple question, hey, somebody in your culture, how would they normally deal with about a low back pain? What's the normal way your culture works with it? And let the patient tell you, and then see if you can co-create a narrative that works well for both of you to move them forward. But I think my kind of earlier years and still, again, improving day by day, but I didn't necessarily see that piece of it. It was just, you're going to fit into Mark Kargela's culture of here's how I do things here, and here's how we're moving forward. And I've definitely moved away from that. And if it aligns some things that I've done traditionally, then sure, we'll go into more of my traditional ways of doing things. But it's definitely and I probably owe this to folks like Matt Lowe and others who've talked about, the third space, John Quintner, Milton Cohen, and others who have kind of talked about this third space and how to create it in a clinical encounter where you're kind of creating that shared narrative. John Warner is another one who's a sharp guy who's really helped us try to get to that story part of it.
And that just comes with, would that just come with listening? Like how does a clinician change, not change what they're doing, but how does a clinician adapt to being able to recognize that culture plays a role? As you said, it took you time before you were able to do that. What was it you started doing that made you created it?
Yeah. I think for me, it was, reading a lot through like Gifford's Aches and Pains books, his topical issues and pain series that he did with some pretty amazing clinicians. Kendall and Linton and Maine and others who are in the psychology realm who talk about psychosocial issues and different things, and seeing, especially, I could only blind myself to studies that were clearly saying that when we look at pain and look at recovery from back pain, for instance, and others, the bigger predictors have very little to do with what you think you're feeling under your fingertips. It's depressions and catastrophization and fear avoidance beliefs and all these things that were coming through that told me that, man, I probably need to talk to the human in front of me, because I ain't going to get that from underneath my fingers. I'm going to get that through my mouth and through my ears to figure that out with the patient. I mean, you can do some screening tools and stuff, but in the end too, I think to me, it's good being a good human being to your patient and giving them a stage to feel listened and heard, and to express their culture and their beliefs and their expectations, and you demonstrate to them that, one, you're listening, you hear it, you understand it, and you're going to respect it, and gosh, you're going to tailor your care to it. Man, I think you can make some huge gains and strides with people. There are definitely people that I would clearly have had no hope for earlier in my career that I feel like I can have a much better chance with, because that there's still things that I can't change that are external factors culturally and society wise and within families and things that I do my best with every patient. But I think, these type of things are crucial if you're going to have a chance with some of these more challenging cases.
Yeah. And I think it's interesting how, so much research is showing us how just doing a simple thing like, treating the patient in front of us like a human being, how much of a positive effect that has on their process of recovery. And it's just so amazing how that has kind of worked out that way, and that there's not a tool or technique you can use that will solve everyone's problems.
Yeah. And I think you read qualitative research, I think, is one of the great, at least for me, and I think one of the most underrated forms of research, because that's where you're getting to know what patients' perceptions and beliefs around their conditions are when it comes to research. And it's scary what people, when you read some of the stuff, read Ben Darlow's work, and Rika Holopainen did some work over in Finland on that stuff. I mean, it's just amazing to see what people, I think we've stripped the humanity out of healthcare. And I think that's one of our big missions with what we do in our teachings and stuff, is to bring the humanity back and stop getting so focused. I think that lack of humanity, because we've missed it, we still think it's just, well, it's this technology, it's just more skilled techniques we need to. I think if we don't need to get that crazily complex with technique, we need to get more human centered and bring ourselves back to where really the foundations of medicine used to be. I mean, gosh, family doctors used to know, they used to make house visits, they used to know everything that was going on with families and their patients, and not that they wouldn't like to now. It's just we've created a healthcare system where it's not even an option for a lot of healthcare people. And these narratives and human experiences get left in the dust and get shoved to the exterior, which unfortunately they dictate a lot more of the outcome than what these biomedical approaches often claim that they're going to predict. And then you get folks like Gilletta Beltons and Keith Meldrums and folks who struggle and fight through a system, and oftentimes get better despite healthcare. And I think we can do so much better for those people.
Yeah, that's a really good insight, I think, to think about. And so if, for whoever's watching this, if they're going back to work after their lunch break or going back to work on Monday, what is something that they could take away from this discussion and start using in their practice with their next patient?
I would say kind of what I alluded to earlier. I think we have this normative style of communication where we're just interrogating the body of the patient. And that's not wrong. I'm not saying by any means we should just because there's this belief or this kind of straw man argument that, folks that are into pain science just talk to their patients. I still treat very similarly. It's just, my narrative around everything I do has really changed in different things. But I would encourage people to say, instead of interrogating, solely what's happening in the body, ask people, well, how does this make you feel? What's been going on in your life around the time you've had this stuff going on? I know I've talked a lot about what's been going on in your body, but tell me what's been going on in your head. I've heard Ola Sullivan say that, and that was one of the powerful statement or question that I've heard him that I've incorporated. Because you see people who come to you in distress, and it's not just because they have nociception coming into their nervous system from the tissues. That nociception has to navigate a human experience and the past experiences and future hopes and dreams of a human, that are getting threatened by their current state of affairs, that if you just sit down, be a good human being and ask, what's been going on with you? This looks like it's distressing you. Tell me about it. You're crying in my room. This looks like it's got you pretty emotional. Can you tell me what's going on with this? And just, again, instead of being this robotic, biomedical, interrogate the tissues and their pathology, that you try to get to know the human that's behind that. And I honestly think it's probably made my career much more rewarding, much more, I get excited to go to work much more than I used to when I was, trying to convince myself that the key to better back pain function was through the SI joint millimeter, movement detection and all these things that I used to try to convince myself
The
of.
wedges,
So yeah,
have them on the wedge.
exactly. I mean, we all have those cringeworthy things that we do, and unfortunately, there's a lot of it still going on. But I think there's people doing some great things in various ways of applying manual therapy. I think we're all doing very similar things. Just I think if we make it about the human, not about our technique, I think that's probably our biggest step.
Cool. Well, thank you so much for joining us today, Mark Kargela, and I appreciate your time.
Thanks for having me. Always good to talk to you, and I love what you're doing in the summit and can't wait to get there this year.
All right, cool. We'll see you then.
Absolutely.